her family. And not only this, but the patient can also end up in the long-term morbidities, which may include the fistulas and the dyspareunias because of the pelvic floor muscular damage, as well as the damage into the pelvis, which can weaken the pelvic floor muscles. So all of these can happen, and this was seen in this study. And they also showed that what are the neonatal morbidities. The operative vaginal deliveries are more associated with the neonatal trauma, brachial plexus injuries, clavicular fracture, intracranial hemorrhage, and the facial bruises. This is about the operative vaginal births, that these are the complications which can be seen with the instrumental deliveries. But on the other end of the spectrum, if you see that the cesarean section at the full dilatation of the cervix is associated more with the birth asphyxia, low cord pH, and more admissions to the neonatal intensive care units and the long-term neurodevelopmental delay. So they also saw that they compare the cervical dilatation, the cesarean at the full cervical dilatation, as well as the operative vaginal birth. The technical difficulties which we face during this cesarean section. As you can see, I have put it in four squares. One is deeply impacted and deeply engaged head. Second one, how you disimpact this head. And many a times, many of our colleagues, they end up in the very extensive tears and the lacerations in the broad ligament, in the lower uterine segment, and the lower uterine segment, which is already swollen up. Sometimes it can slip away below the bladder, and sometimes it kept on bleeding and hemorrhage. These are all the things which can happen. And then there is a which technique is to be considered for avoiding all of these complications. And at the same time, previously attempted instrumental delivery before we proceed to the cesarean section. No randomized control trial were seen in the Cochrane review. There are only few cohort studies, but there is a decrease in the pH if the trial of the instrumental and then cesarean section versus immediate cesarean section. In the literature, I saw that actually there is no randomized control trial. But the cohort studies showed that if previously the patient has undergone some of the instrumental delivery, like the forceps or the vacuum, and then she goes for the cesarean section in the second stage, it is associated more with the decrease in the cord pH as compared to those cesarean sections where there was no previous attempt at the vaginal birth through the instruments. This was one of the association. So these are the difficulties which are to be there. The techniques and exposure. There are no specific international guideline, for example, by the NICE, as you know, National Institute for the Health and Care Excellency, or from the RCOG for performing the cesarean section at the full dilatation successfully and safely. However, the intrapartum guidelines for the high-risk women are currently being developed in this regard. So maybe very soon there can be a guideline regarding the cesarean sections, techniques, and the difficult scenarios, and which may include one of this type of the cesarean. Next, we come across to the exposure. As we know that the NICE guideline recommends the jewel cone incision for the cesarean section, and in this picture I have put this to show that what is a jewel cone incision and what is a Pfannenstiel. This one is the usual incision which most of our colleagues are using. This is a jewel cone incision, and this is a Maryland incision. So they are recommending with this type of the cesarean, we should do the jewel cone incision. And what is a jewel cone incision? I took this one from the talk where it was written that this is a transverse incision of the choice should be used at, which is a straight skin incision, and it is about 3 centimeters above the symphysis pubis. And we know that usually we do the cesarean 2 to 2.5 centimeters above the pubic symphysis. And then most of the time we do the sharp dissection. But over here, the difference is the distance, which is about 3 centimeters, which is slightly above the Pfannenstiel incision. And secondly, the subsequent tissue layers are opened bluntly. And if necessary, we can use the scissor, but not a knife, because it is associated with the shorter operative times and reduced post-operative febrile morbidity. This is an evidence level A, and it was published in 2004. So this is the evidence which says that the jewel cone incision is much safer as compared to the Pfannenstiel incision. Regarding the uterine incision, again, this is a very difficult part where one should be very expert in it. And the lower uterine segment is stretched up, we all know, edematous, and it is tired up from the previous labor and too much prolonged labor, impaction, and maybe the syntocinon, and the patient is pushing. So all of these things then put the lower segment of the uterus at risk of rupture and the injuries. So that's why once you see the lower uterine segment, as most of us know, that it is usually edematous and it is there is edema, there is a stretching. So it is difficult even sometimes to recognize the proper landmarks. So over here, the good proper exposure and a planning before you give the incision is the key point in order to avoid the complication. And it is a good practice point to give the incision a little bit higher up as we do for our routine cesarean sections. And the most of the studies are also saying that the incision can be U-shaped and it can be to prevent the trauma to the broad ligament of the uterus. I personally also do the U-shape incision, and I have seen that it is associated with lesser morbidities and the mortalities. Then next comes the disimpaction of the head, which is the most challenging time. And here, the skills and the experience of the surgeon matters. This is the most important thing. There are the difficulties, and these difficulties are co-founded by the uterine contractions. As you know, that the liquor has been drained, and the uterus usually it hugs up the baby, and it is difficult to have the impaction of the disimpaction of the fetal head or the presenting part, whatever is. So for this purpose, the studies says that you should stop the syntocinon, and some of the surgeons, they also give relaxant, and by asking the anesthetist to give the halothane or sometimes the placebo, but its association with the postpartum hemorrhage is still in query because the relaxant can give rise to the postpartum hemorrhage later on, and the laxity of the uterus and atony of the uterus. So different people, they do the different things. However, the preoperative assessment and pushing vaginally, this is one method where you can just push the head from down. You can ask your assistant when the patient is shifted in the theater and you are giving the incision, she can push the head from down. I have faced this difficulty that this is most of the time is the practice which our colleagues do, but I have seen that this is most likely associated with more injuries and also with the more tears and laceration. You are pulling the head from above and the assistant is pushing the head from down, and you never know where you are and what is going on. The one good thing is always keep the head flexed. This is the key point. Always keep the head flexed, and please do not be in a hurry because the placenta is attached and the patient is under your control and you can take the baby with few minutes. Don't be in too much stress, and don't try to do it as hurriedly as possible. Take your time, plan it out from the beginning, your incision, your everything, starting from the skin. And over here, now the studies are showing that there are three methods which we can use. One is the push method, second one is a pull method, and third one is the Patwardhan's method. The push method is intraoperative method. As I told that you are pulling from the above and the assistant is doing the pushing from down. So it has got its own pros and cons. And the pull method, pull method is in which you just gently put your hand, your dominant hand, and you just try to see where is the feet of the baby. So you can just do the reverse breech and you can extract the baby as a breech. This is called as a pull method. That is, you are pulling the baby. And it is associated with lesser injuries and the lesser postpartum hemorrhage and more successful as compared to the other method. Nowadays, they are also saying that Patwardhan was an obstetrician and who said that you just deliver the arms of the baby and the body of the baby and then the legs of the baby and then the head of the baby will come automatically. So this method is not very well practiced, but maybe some of the people, they are practicing it. I never practice this method because I find it difficult and I'm still not clear that how this Pudwarden method will work. Anyway, this is one of the method that where some of the people might be confusing at this point. I just want to make it clear that Pudwarden method is in which you opened up the uterus, you take the arms of the baby out, then the body or the feet, whatever you can take out, and in the end, you can take out the head. This is this method. And nowadays, there is another technique which is called as a non-dominant hand technique or fetal head disimpaction system. Myself has experienced a very good success with the non-dominant hand technique, in which usually I am a right-handed person, so I use my left hand lower down and I just keep the head flexed, and there are very less injuries if you use the non-dominant hand technique, and this is not associated with any injuries or morbidities or the mortalities. If any one of you is practicing, might be they will be they can share their experience with us over here. And nowadays they are developing one of the cushion system which is called as a fetal head disimpaction system. This is also available in the European countries, and at a few of the units in the NHS, they are utilizing this fetal head disimpaction. What is it? We will see it. Now, here is a comparison of the different techniques which are used to deliver a deeply impacted fetal head at full dilatation. This is a systematic review and meta-analysis. It was published in BJOG in 2015. And over here, they tried the different techniques and then they published it, this research. It was done with the help of an online search starting from 1946 to January 2015, and they searched for Embase, Web of Science, and the Cochrane Library database. And over here, they said that they included the 12 studies, and 6 studies were examining the primary outcome, and rest of the 6, they were studying the primary and the secondary outcome. The meta-analysis showed that the risk of uterine incision, extension, infection, mean blood loss, and operative time were significantly higher with the push technique as compared with the reverse breech extraction. As we discussed that the push method is having its own pros and cons, and it is associated more morbidities and the mortalities as compared to the pull method. And the pull method is a reverse breech extraction. The evidence to support the Pudwarden's method and the fetal pillow was inadequate in their study. So over here, I took this forest graph from there, and you can all see that they have got the push method versus the reverse breech extraction, odd ratios, and also again over here, push and pull along with Pudwarden's method. And you can see that over here, the studies are favoring more towards the reverse breech. And some of the studies, when they are doing the push and pull, they were in the favor of Pudwarden's method. But still, there are no randomized controlled trial to say that Pudwarden method is really a good method. And up till now, the pull method is the one which is being supported by most of the studies. And over here, they saw the operative time and the blood loss, as also the blood transfusions in push method, reverse breech extraction. And over here, you can see the diamond, which is also showing the favor of the reverse breech, all of them. And over here, the blood transfusion was the same as the diamond is touching this line. And you can see that it is the same in both these methods. If the people are familiarized with the forest plot, I think they will be enjoying this slide. Then the postpartum maternal infection was less in reverse breech extraction, which is our pull method, and it was more in case of the push method. Over here, there is a publication by the TOG, the obstetrician and gynecologist. This is a journal by the Royal, this is a journal by the British, and there is a reducing complications associated with the deeply engaged head at cesarean section. And they said that there is a simple instrument, as we said before. What is this instrument? They said that this is a type of the fetal pillow, which they insert through the vagina. And over here, you can see that folding base plate, this one, with rounded atraumatic edges. And then this is a silicone balloon, and they just uh, push it through the vagina to the fetal head, and then the pressure is applied through the 60 ml syringe and the tubing. And they are saying that due to this pushing of the water through this syringe, which is a 60 ml, so that there is a they can just push the head up, and hence the head can be delivered through the incision. But still, the studies are not favoring this type of the instruments and all of this. Anyway, this was just to be to share that there is something which is available in the European countries and in the NHS, but they did not publish the studies about it. So maybe in a couple of years we can see the few studies and the experience of the obstetricians, and maybe they will be available later on. So the other techniques, which are the other techniques? Many other techniques are anecdotally described. There is no evidence base, but they are saying that few of the other things which we can do is to position the woman in Whitmore position, which is a modified lithotomy. This position is a modified lithotomy where the thighs are moderately abducted and flexed at 135 degrees from the trunk. It can optimize, then we can also optimize the surgeon's position. For example, the use of a stool or low patient the bed or lower down the bed of the patient, or use of a non-dominant hands to apply an even traction to disimpact the head. However, there has been no established evidence. These are the techniques where we need to experience and to write more research articles, and we need to have the more research in this regard, whether they are helping the obstetricians or not. Then the trial of the instrumental delivery in the theater versus the immediate cesarean section for anticipated difficult assisted birth. I put this slide that sometimes we are thinking that maybe this will deliver or this will not deliver. So there was a study which is a Cochrane database, and it is a systematic review which was published in October 2008. You can see that. And they said that whether should we go for the operative vaginal birth before we go for the cesarean section at the full dilatation. What should be the decision? So some of the obstetricians, they are very fond of doing this to bring the patient to the OR. And there are the two teams. One is for the abdominal delivery, another one is for the vaginal delivery. And they try the birth in the theater with the help of the instrumental instruments, maybe the keel and forceps or the other forceps mid cavity, or the ventouse, whatever is the plan of the surgeon at that point. So they said, can we do that? Yes, you can do that. If someone is comfortable with it, you can do that. And if somebody can be successful by doing the vaginal delivery, and he or she is expert in it, we can avoid the morbidities and the mortalities associated with this type of the cesarean, which is very difficult. These data suggest that the maternal and the neonatal risks do not seem to escalate following an attempt at operative vaginal deliveries. This is about the previous slide, that they showed that it does not increase the maternal and the neonatal risk if it is to be done in the expert hands and there is a support from the senior obstetrician. But over here, you should think about the gestation, duration of the labor, prior to intervention, CTGs, and the scalp sampling should all guide the management decision in order to avoid any medical legal issues later on. So the conclusion. In the conclusion, we should say that cesarean section in the second stage of the labor is rising in these days, and there is insufficient evidence to recommend the specific techniques for the delivery of the cesarean section at the full dilatation. But however, the studies are more supporting towards the reverse breech or the pull method. And as we have seen through the different studies as well. And anyway, the surgeon, whatever he or she likes and is comfortable, is the one which he or she can adopt. The ultimate idea is to have the safety of the patient and not to jeopardize the safety of the patient at any point. So this is our main idea and the main theme to treat the patients. I think somebody is not muted. So over here, the expert opinion on the techniques and the consensus in interpretation of the well-designed, non-experimental and descriptive studies are required in order to formulate an acceptable management guideline. Until a guideline and a training program is created, it is important that the obstetrical trainees have adequate supervised training, opportunities to improve the recognition of a real need for cesarean at the full dilatation, as well as the competences and the confidence for performing the vaginal instrumental delivery. So this is the nutshell, and we should always never jeopardize the safety of our patient at whatever level we are working. If we need an opinion of our colleague or somebody who is working at the consultant, we should never hesitate to involve the second consultant in the second opinion, because we don't want to put the patient at the risk of short-term or the long-term morbidities and the mortalities. And the people who are just relying upon the specialist to do the cesarean in the mid of the night, the consultant should attend that cesarean by him or herself, so that if there is any difficulty at any point, he or she can take over the procedure in order to avoid any problem to the patient later on, short term and the long term. So this was all about today's lecture. And in nutshell, as I said, there are the different techniques which can be applied, and the pull, push, and the cushion techniques, whatever is available at whatever point, one can practice that. So you are welcome for any question, please. Yes, Dr. Shadi, is there any question? Hello? Hello? Can anybody hear me? Hello?
So, 1 second. حد عنده أي أسئلة دكاترة؟
I hope that everybody just listened to till the end of the slide, because I think there was some problem in the...
لا, it wasn't the first of the lecture, and I think it's done.
So everybody just attended the whole part, or some
Yes.
slides are left?
And it is streamed in YouTube if anyone want to check the lecture again.
So please, anybody wants to talk, want to ask, please, you are welcome.
Thank you, Doctora. Wonderful lecture.
Thank you very much, Dr. Hanan.
Thank you, Dr. Yasmin. I hope we see you soon. Another lecture. Thank you for all attendance. You can see the lectures on YouTube and Facebook, ASF, the society page on Facebook and YouTube.
So this lecture is on the YouTube as well?
This lecture on YouTube and the first one on Facebook.
Great. That's good. So the people who did not attend, they can attend it later on.
Yes.
So there is no question. Everybody knows everything, I think.
It was very clear, Doctor, and thanks again for joining us.
Thank you very much.
السلام عليكم. نشوفكم قريبا إن شاء الله.
Inshallah. Thank you very much.